Please welcome Dr. Christopher Moores for a discussion on the public health response to the coronavirus.
Thank you for, I'm sure, an enthusiastic, passionate, albeit smaller crowd, but they'll come after lunch.
Tough coming after lunch.
Right,
yeah,
right.
Yeah, so.
Well, I'm Rick Berke from STAT, and I think we have a particularly timely, important panel right now, which is obviously public health and the coronavirus. I'm here with Professor Christopher Morris, who's a professor and program director in epidemiology and global health and disease control at George Washington University School of Public Health. And first of all, Chris, can you, and first of all, we have a new name here of the virus in the last 24 hours, COVID-19. Explain that.
Yeah, so it seemed to be a rather important thing for the WHO to rename the virus or officially name the virus. And they took great pains to not implicate the geographic origin of the outbreak and the virus there because they feel it stigmatizes the areas when traditionally we'll name viruses after the location they're found in. So they arrived on COVID-19. And it's not unlike a number of the other coronaviruses, but there's 4 other coronaviruses that are endemically transmitted among people, and they have kind of wonky acronym-like names. So,
can you? We have a graphic we'd like to show where we can show a map of where coronavirus has spread. Can you fill us in right now on the latest?
Yeah. So this is a screenshot from a dashboard that's maintained by Johns Hopkins, and they pull their data from the Chinese data stream, WHO, CDC, and they all kind of feed out of the main Chinese data stream, and those that are coming out of the provinces there in China. And so you can see we're up to 45,000 cases and 1,100 deaths as of today, and more of China gets covered in this this red blotchy, scary sort of concentric circles here. And so at the bottom there, you can also see the epidemic curve as reported by the Chinese. And so the yellow rise there are the total number of confirmed cases. And then underneath it, the green line is recovering cases. And the yellow line that's all the way at the bottom and flat, those are the cases that have been accumulated outside of China, outside of the outbreak zone. So you can see it really is still, even though we have a number of cases outside of China and outside of Hubei province, it hasn't really taken off yet in those locations.
Now, you're a veteran of outbreaks. You were on the ground in West Africa for Ebola, in Peru for Zika, among other places, and other outbreaks. How is this different?
So this is a brand new virus. So in the other cases, I mean, they're new locations. So the way we travel and move ourselves and goods around the world now, we introduce viruses all the time, and sometimes those take off in fantastic ways, like they did for introduction of chikungunya and Zika to the Western Hemisphere. You can have an emergence in a new location like Ebola in West Africa, where we really hadn't necessarily seen that before or expected it. But in this case, this is a brand new coronavirus. So much like SARS back in 2002 and also MERS 8 years ago, these are viruses that are new to our understanding as disease agents of man. So,
you said even since you've been at this conference, you've had people come up to you and ask how concerned they should be in this region, just in general.
Yeah, I mean, it's certainly the first question you get asked when people start talking about this is, do I have to be wearing a mask? Do I have to worry about this right now? And unless you're in an area where there's active transmission going on, the main thing you can do is just try and keep your social distance and try and wash your hands and such. But there's no indication right now that we have ongoing transmission outside of the outbreak zone. There's a couple of spots where there's been more cases, including Hong Kong and Singapore and Thailand. But even there, it's a very low number of cases, and so In general, people should be wary, but not overly concerned. It's difficult, though, when you see the media coverage of this, and the responders in the outbreak zone are all fully PPE covered, just like it was for the Ebola outbreak. So it does elicit a lot of fear.
Speaking of media response and social media and so forth, given the explosion of social media, is that bad for something like this? I mean, it's different from even with Ebola and Zika in terms of how people are responding to the perhaps alarmist nature of this.
Yeah, I mean, I guess in this case, I would take the social media, I give them a little more credit than I often do, because of the fog of a brand new virus, just 2 months into our knowledge base with it, and the fact that it's going on in China, which is a fairly closed off area. They've done a decent job sharing data, but not nearly enough for us to understand what's going on in terms of transmission and pathogenesis there. And so whenever we can glean a little bit more data from social media reports, and you have to take them with pounds of salt, it does give us a little extra peek into what might be going on the ground.
Now, how did you get in this business?
Well, I decided I was a microbiologist and wanted to be a virologist, and got really interested in emerging viruses back in the 90s when there was a series of fantastic books and movies that kind of, glorified the response to those sorts of outbreaks. And I went ahead and got my degrees in it and kept after it. And so it's been a really exciting career, and I certainly do very much appreciate what we can learn from outbreaks and how that should hopefully inform us for the future and help us prepare better.
When you've been to places where there are outbreaks, how nervous do you get?
I'm really not nervous. I'm careful. I'm not cavalier, but I'm not nervous because I feel well trained and prepared for those situations. And so it's not something that I do in a way to kind of throw myself at it and hope I get infected. Not one bit. That was my every day in West Africa was making sure first I kept myself and my clinical team and my surveillance teams alive. But we had a job to do, and so once you mitigate those risks, get out and get on with it. So.
Now, we had a story, we've been covering this at STAT, and we put all our coronavirus stories in front of the paywall as a public service, but probably our one story that's gotten the most attention to this day, and let's show it on the screen, is about 2 scenarios of where we could end up going on coronavirus. We talked to many experts on this. One was that one scenario would be like sort of a common cold and would sort of be the 5th coronavirus in existence, and it would crop up here and there. And the other one would be a more sort of sinister, sort of flu-like disease. Anyway, could you talk a little about the scenarios as you see them and what you think could happen?
Sure. So let's start with the 2 scenarios that aren't in this paper here, because those are the ones that are a little more unlikely, right? So the first would be that this strenuous response by the Chinese and the international community to travel restrict the outbreak area somehow damps this thing down, and it's driven to extinction, much like SARS was. There's enough going on right now in terms of community transmission in a larger space across China that doesn't seem particularly likely. And so it does seem that it's going to continue to go, and it's going to get outside of the main outbreak zone at some point. The other is that it's not going to become like airborne Ebola. So we don't expect that this virus is going to change its stripes too quickly. It should be fairly well genetically constrained, is the expectation. And so, the pathogenesis and the case fatality rates we're seeing now, if they're accurate, would not suggest that we're going to suddenly see a massive change in how this thing operates as it does progress in the outbreak. The 2 scenarios in this article here talk about one where this virus becomes, as you said, a 5th endemic human coronavirus. The other 4 coronaviruses causing mainly colds in people. They circle, annually around the globe, and they do cause pneumonia in people with risk factors, and they can cause deaths that way too. there's plenty of reason to expect this virus could become endemic in that same way. There are some key differences, though, where this new coronavirus does seem to cause quite a bit more fever and may have a higher case fatality rate than the others. Now, it's brand new. The whole world is naive. No one's ever been infected with it before. And so it could be that those other coronaviruses, when they first were establishing in people, because they all came out of animals at some point, that they also had a greater level of pathogenesis and ability to create disease that's been attenuated over the many years. That seems quite possible. The other scenario in this article talks about that higher case fatality rate that's currently being reported from the outbreak zone of approaching 2%. If that holds, that's a very nasty case fatality rate. That's coming close to the 1918 flu strain level of case fatality. And so if it gets out and causes a pandemic, that could be a serious impact on a global scale in terms of loss of life and morbidity and an interruption of all other things that we do on this earth. So that really depends on whether or not the data and the case fatality rate that we're having reported to us from inside the outbreak zone holds up. I think at this point, there's not a lot of evidence to suggest this is going to be stopped, and it's not going to have some fairly good opportunity to make at least one pass around the globe. And so at that point, it really depends on whether or not the pathogenesis and the case fatality rate hold up.
Now, it's been said we love responses, but we hate preparation. How prepared has the world been for this?
Well, we tend to, make our investments in the heat of the moment. And once that heat is turned down, those investments and concerns go to the next fire. And so there hasn't been a lot done on coronaviruses, frankly, outside of small blips of research funding and interest from SARS and from MERS recently.
Can we, by the way, switch to the next slide while you're talking? Mm-hmm. This is about that very subject that we wrote a story about. Fluctuating funding and flagging interest have hurt the research.
Yeah, so I mean, I think we should know more about all of these threats. And so there's been a number of different efforts to understand what are the things out there on the horizon that haven't quite gotten into us yet, that have the potential to cause pandemics and disrupt systems that we have here that we could otherwise mitigate by making appropriate investments in research to understand the threat, but also into resilient public health systems that are there and waiting to respond, so that we're not trying to assemble them mid-flight.
Mm-hmm. What frustrates you the most about the agencies handling this, the WHO, the CDC?
Well, I mean, I think that,
or are you really happy with it?
No, I mean, from my conversations with my colleagues at CDC, I mean, it's been an access issue, and so that gets back to why haven't we had, a better level of sharing of information and access to the outbreak zone. China's been making a very strenuous response to this, and they've shared some data, but there's a lot of fog. I mean, we're only 2 months in, but there's a lot of fog in terms of what's really going on. What are the transmission rates really looking like? And so it would make me feel better for sure if I knew our best experts were on the ground there as a part of that response from the get-go. So here we are now, 6 weeks in from really the reporting of it to us, and so that's a lot of lost time. So I think as we started off with, the WHO's response has been waffling and really, I think they haven't been as strenuous in terms of trying to enforce an opening of access to the outbreak as well, and so that's not the leadership I would want from WHO in terms of an outbreak like this.
How about CDC?
CDC is, as far as I'm understanding it, has been ready to go and willing to go. It just has not been something that the Chinese have let us do. And so that's an important lesson for us. If we're not going to be able to rely on that kind of openness in a highly dynamic outbreak situation like this, we have to start taking ownership of our own preparations here as the rest of the globe and individual countries to make sure that we are preparing for the incursion of this virus, which could be quite likely. and make sure we're not relying on the response there in China at the outbreak zone to absolve us of our responsibilities.
So when you're talking about fog, you're talking about WHO.
I'm talking about just the data stream. So we have a nice dashboard there, and we're looking at the data coming out of the outbreak there. But it's what we're being offered, and it's not what we're asking for. So what we're asking for, and what we should be asking.
Let's go back to that first slide.
What we should be asking for is a much higher granularity on the data from the outbreak zone. This doesn't give us a lot of information on who's getting diagnosed, how they're being diagnosed, what falls into each one of these different colored columns here, the definition of cases and things like this that really drive our calculations of transmissibility, of case fatality. These are critical because that's how what we're going to go forward with and how we're going to try and make our plans as individual nations. And so if this is somehow being obfuscated by either a lack of confirmatory testing or recently there was a decision that it seems to be verified now that the Chinese are changing the case definition here in the last 2 days, which will drive some of the cases down and might make the curve look like it's tipping a bit downwards. But now it's not requiring the clinical signs, so it's just a confirmatory test. But if not everyone is getting that confirmatory test, and there's a limitation on that, which we don't know for sure, that could also be really wildly changing our expectations here. And a number of colleagues out there think that the number of Hilda cases is much higher than what this map is showing.
Where are we on a vaccine?
Yeah, so I mean, part of that goes back to the boom and bust of research interest, right? And so there's been a little more durable interest now recently in emerging virus preparations for vaccine and stockpiling and such. But with a brand new virus like this, we're just not ready for it, and so we're going to start from zero. And I think that there are some really interesting advanced technologies out there that should advance us very quickly. We need to have the regulators come and meet us, along the path there and not provide a wall, so that some of these more rapidly deployable or advancing technologies can kind of get us there. That goes for diagnostics as well. I think waiting and relying on one diagnostic from the CDC, they are the gold standard keepers. But I think we also need to get a little more aggressive at getting diagnostics that we can trust and verify, put it out there as quickly as possible. And so, like we heard yesterday, the Aptamer-based rapid diagnostics platform that our colleagues here at this meeting were developing, things like that I think could really change the game here in terms of getting diagnostics out there to help us understand the outbreak better if they were deployed.
What kind of realistic timetable are we talking about in terms of a vaccine?
Well, so the vaccine, I mean, I think Director Fauci said, it's at least a year, and there's no way it's really going to be less than a year. So I think we can just look at the Zika outbreak of late and the Ebola outbreak of late, where there was a push to try and get those vaccines out to the field before the incident cases drops. We could verify and validate those products. But in both of those cases, the vaccines arrived too late to really evaluate them in the context of ongoing transmission.
When you say or he says at least a year, isn't that wildly optimistic?
I think it's a hand wave. So I think, yeah, it could be optimistic. We have the technology, I believe, to actually achieve that. And if we look at this as a pandemic and a slow roller, right? Then that could actually, if we hit that mark, we could actually have something perhaps in time to really protect the most vulnerable populations. So, but we have to stay on it.
But based on your experience, in terms of making this available to all who need it, what's realistic? What would be more realistic?
I think it really depends on whether or not this keeps going or not. If it starts to settle down and people lose interest, that's going to cool off that R&D pipeline as well. I would hope that they could put this together, though. I mean, if this really is looking like it could potentially become pandemic or endemic, and it could potentially have a higher case fatality rate than the other coronaviruses that are currently out there, then there should be nothing holding us back right now to push as hard as we can. And I'm sure the folks inside NIH are doing that right now.
In the final seconds we have up here, any misconceptions that you want to address right now about how bad this is, how serious it is, how people are reacting?
Well, I think we honestly need to take this very seriously. So again, without trying to say, oh, it's only going to be as bad as the flu or something like that, and it's not as bad as Ebola or MERS or SARS. That does a disservice to this. If this is transmitted at a really broad level and potentially globally, we're talking about a significant impact on the health of vulnerable populations. Moreover, I think that the impact to the global economy of some of these more draconian measures of quarantine and travel restriction really portend a broader impact on health as well as economy, because we know that those people that are needing health care and needing supplies are going to have those supply chains and those services interrupted by all that.
Great. Chris, thank you very much
Thank you so much for having me.
all your timely help. Thanks so much. Thanks.